local experience of EBUS in MH. Thank you.
Bismillah ar-Rahman ar-Rahim. After the international flavor, now we come to the local flavor in Pakistan. Respected seniors and dear colleagues, I am Colonel Muhammad Amir and working at Military Hospital Rawalpindi for last 2 years. This is the sequence of my presentation. I will show one short video of endobronchial ultrasound, which is available in few centers in Pakistan. Endobronchial ultrasound is used to visualize mediastinal structures and lymph nodes on tumor adjacent to the central airways. It is performed as an outpatient procedure and under conscious sedation. The lymph node stations which we can reach by EBUS is 2nd, 4th, 7th, 10, and 11. And other stations we can reach by EUS, and we can use combined EBUS and EUS also. The indications is for staging and diagnosing the lung cancer and visualizing peribronchial lymph nodes and metastasis, and localize the peripheral pulmonary lesions, which we do with the radial probe EBUS. Contraindications are simple, that he doesn't have any cardiac arrhythmias, recent or current MI, heart failure, or he is severe hypoxemia and is uncooperative patient. And we should rule out the blood dyscrasias before starting the procedure. We should have his recent PTTK. It is a minimal invasive and having highly diagnostic yield. It does the real-time imaging, unlike the CT and PET scan. EBUS can assess a wide range of mediastinal lymph nodes. It can sample a lymph node of size even less than 10 millimeter in short axis. But we cannot read some lymph node groups, as I already told, that it may be a subaortic or paraesophageal lymph nodes, and it is a costly equipment, and it is available in few institutes in Pakistan. And to use it, we need a lot of training before using it. 2 types are available. One is radial probe and other is convex probe. This is a radial probe and that is convex probe. Yes, pointer. This is the radial probe EBUS. It has a 360 image of ultrasound image, this 360 image. And then it can localize the tumor. This is convex probe, which is mostly used, and it has a small, this is ultrasound, this is from where we can do the ultrasound of the lymph node, and this needle is used to take the transbronchial needle aspirations.
This is a video of an endobronchial.
I will show a video of the procedure.
The patient has a primary lung tumor. A lymph node in the mediastinum is to be examined for metastases. Both the tumor and lymph node show high uptake on the PET CT scan. The ultrasound bronchoscope is inserted down into the bronchi. The scope has both a camera and an ultrasound head. The lymph node is located using ultrasound, and the scope is placed in the best position for the biopsy. The aspiration needle is placed in the working canal in the scope. Guided by ultrasound, the needle is inserted into the lymph node. This is the needle in the lymph node. The introducer is removed from the needle. Using a syringe, the operator aspirates while simultaneously moving the needle back and forth in the lymph node. After the aspiration, the material is carefully pressed out onto a slide. The material is smeared using another slide. The needle is then rinsed with saline solution. The test material is stained with a rapid stain and immediately examined under a microscope by a pathologist. He controls that there is sufficient material from the lymph node for an analysis.
When we see the lymph node, we have to assess if we have an idea that it may be benign or malignant. When a lymph node is benign, there is usually absence of necrosis and hilar fat is there, and it may be have indistinct border or oval shaped. Whereas in malignant,
This is a video of an endobronchial ultrasound.
in malignant there is have rich blood flow. It is vascular, so we can use the look that whether it is vascular or not. And we see that there is sentinel necrosis is present. Yesterday we did a workshop at MH Rawalpindi, and the lymph node was having lot of necrosis in it. So black material was aspirated in our first pass. And it has heterogeneous echogenicity and a distinct border is seen. The complications of this procedures are very few, less than 2 to 3%, which may be hypoxemia and laryngeal injury, because the head of the scope is larger than the normal bronchoscope. It may cause some laryngeal injury, and in beginners can broke the equipment also. It is very costly equipment, and there may be some other effects due to local anesthesia or procedural sedation. This ends the first part of my presentation. And which place is this? It is a beautiful place at Sawat Malam Jaba. We started EBUS in 2010. General Aslam Khan was the pioneer in doing EBUS at Military Hospital Rawalpindi. Ali Musani came and we had a workshop there in MH Rawalpindi in 2010, which was attended by all of us. Till now we have done total about 874 procedures. In COVID, we had a fall in the procedures in 2021. Our resident did a study last year from February to July 23. And we included patients of more than 18 years of both genders having suspected malignancy. We excluded the patient having severe respiratory distress or any cardiac conditions. And patients suspected were included in the studies, and we did data was collected and analyzed on SPSS 26. Demographics include most of our patients were male and having few comorbidities like diabetes and hypertension, and 1/4 of patients were also smoker in it. And here comes the result. The most common tumor which we found was adenocarcinoma. And some metastatic tumor we were also detected. Primary was in renal cell carcinoma. We also find benign conditions also in our study that most common was tuberculosis. And we tell the patient if it comes out to be TB, that is a मतलब उसका शुक्र अदा करना चाहिए कि टीबी निकल आई है, malignancy नहीं निकली. और diagnostic yield हमारी जो थी was 88%. 11% we missed the diagnosis. So limitation of our study was that it was a small sample size. we took, and it was done at a single center. And next time we will collaborate with other centers doing this and make a large sample size. So as compared to the CT alone and PET scan, EBUS has a high diagnostic yield. It has specificity of 95%. And it has advantage over mediastinoscopy that it doesn't require any general anesthesia, and it is minimally invasive procedure which provides real-time imaging, and precise sampling can be done, and it has high diagnostic yield and safety profile, which make it a preferred choice for evaluation. These are my references which we used in study. Our study is being published in Pakistan Armed Forces Medical Journal. This is my institute. You are welcome at Pulmonology Department, MH Rawalpindi. We did a workshop yesterday and lot of people attended it. And inshallah we do it after some time. We can repeat this workshop. Thank you very much.